again, as somebody who moderates myself a lot of events, I know how much work it is. And my favorite moderator on the planet was luckily available today and has moderated a number of important sessions for us on various issues, social justice, the USMCA. She also travels the world in moderating big, important conversations. Before that, Jean Meserve, as I think everyone knows, is a accomplished, acclaimed broadcaster, journalist. And so my favorite part of this is I get to turn it over to Jean. And thank you all again, my friends, the panelists and the participants, and we're going to have a great discussion. So over to you, Jean.
Yeah, thanks, Scotty. And just to improve my cred with all of you who are Canadians, I'm also an international security expert for CTV News. Just had to get that plug in. I wanted you all to know that I recently interviewed a former U.S. intelligence official who said to me that his credo was never let a crisis go to waste. He said it was a perfect opportunity to assess what your weaknesses are and correct them. And sometimes a crisis provided an opportunity to really make revolutionary change. So it is no doubt that the pandemic has created a crisis for all of us in terms of our economies and also our health systems. So the question for all of us is whether we're going to do as this intelligence official suggested and seize the day. Are we going to take this moment to reinvent and reconfigure and make things more resilient? We have a stellar panel assembled today, as you can see, but before I introduce all of them, I want to turn things over to Jana Remnes. Jana is an economist and a partner with McKinsey Global Institute. She is going to summarize the principal findings of a report recently done by McKinsey entitled Prioritizing Health, a Prescription for Prosperity. Jana, over to you.
Thank you so much. And thank you for inviting me to join the conversation. I very much look forward to it. But as an economist, until COVID pandemic, health was not part of the economic growth discussions, as economists have been completely focused on the cost of healthcare and whether we can afford it as populations age. Our research found that this is a mistake. Even before the pandemic, the developed economies, they lost 15% of the GDP because of ill health. People were dying too early or suffering from chronic conditions that didn't allow them to fully participate in socially or economically. And this cost reflects the fact that in North America, 1 in 5 workers suffers from a chronic condition, whether it's back pain, anxiety or depression, or migraines or headaches, and particularly in the case of North America, unfortunately, substance use disorders. These all collectively contribute to chronic diseases that make people more likely to retire early, be more absent, and suffer more from presenteeism, which is that they are at work, but they really can't be as productive and as focused on their work as they could be. On the flip side, of course, this cost is an opportunity. If we rethink health as an investment with the return, we can get very large returns. Our research shows that we could reduce the projected health burden in 2040 by 1/3 in North America, simply by adopting interventions that we already know how to do. 2/3 of these are preventive, whether it's changes in lifestyle that lead to increases in risk on many of the chronic conditions, but also at sustaining practices of taking your medicine more frequently, as well as more consistently, as well as, of course, some of the therapeutic treatments, from surgeries to psychological and physical conditions. And the economic returns for this would be very, very high. First of all, of course, we all know the social benefits would be high. We estimate that you could add 10 healthy years to every individual, making 65 in essence the new 55. Who wouldn't want that? And in addition to that, we could increase GDP in 20 years' time by 10%, which over the 20 years means 0.5 percentage point faster growth than what we are projecting right now. And that's really exactly what we need coming out of the pandemic. And it doesn't need to add to healthcare costs. We actually estimate that the returns would be 3 to 4 times for every dollar invested. So that's the good news, very much in the spirit of let's not waste a crisis. We really would love to see a real change on the ground to make sure that we don't just return to the past, but really set us into a path for a much healthier future ahead. And let me just finish. Of course, if we address the 30% that we have solved, it still leaves 70% of the disease burden unaddressed, which leaves large room for innovation. I know this is going to be one of the big topics for the panel, and we definitely need to find new treatments for diseases we currently don't have a good treatment for. We need to be more effective in real world situation in the effectiveness of the treatment we know, and perhaps most importantly, change make it easier for people to adapt to healthy behaviors that reduce their cost of chronic diseases. So with that, thank you for the opportunity to share some of our, I think, what is a very exciting agenda for us ahead as we look coming out of the pandemic.
Jana, thanks so much. Now let me introduce the rest of the panel. Victor Fedeli is Ontario's Minister of Economic Development, Job Creation and Trade. Fred Horn is Alberta's former Minister of Health. Angela Baboudi is Director of Government Affairs and Advocacy for Amgen Canada. Louise Binder, is it Binder or Binder, Louise? Oh, you're muted there.
Oh,
there. Tell me the right pronunciation. Is it Binder or Binder?
Binder.
Binder is a Canadian lawyer and a patient advocate, and also with us is Howard Dean, a physician and a former governor of the state of Vermont. Thank you all for being with us, and let me remind the audience that we want your questions. And if you put them into the Q&A function, I will be able to read those and I will integrate those into our conversation. So please, fired away. Minister Fedeli, let me start with you, if I might. Healthcare is most often talked about as a cost. From where you sit, do you think healthcare can and should be seen as a strategic investment, as Jana's report suggests?
Thank you very much for the question, and it's a pleasure to see you, Jean. Jana, congratulations on the paper to you and your colleagues. I read it with great interest. I know our government was very interested in it as well. We would absolutely agree. I mean, the title, How Prioritizing Health Could Help Rebuild Economies, really does say it all, and I hope by the end of this hour we can see why. It certainly has helped us throughout this pandemic as well. Jean, you talked about making things more resilient. I hope that as we discuss, we can talk about the changes that we made here in Ontario, the largest province in Canada. We made significant changes in our PPE acquisition, the types of vaccines that we actually manufacture in Canada today, some of the strategic investments that we saw the pharmaceuticals make. So we've seen a real change there. But to Jana's paper, the opportunity now, when we think about pre-pandemic, we had about 250,000 jobs that were left unfilled. And when you think about the fact that you can add this 10 years that you spoke about, I felt younger already just listening to you. That is a way to complement the job market. So I'll look forward to chatting more about that.
Minister Horn, if I might ask you, did the pandemic demonstrate that to this point, at least, Canada has not made the right investments in healthcare?
I think the pandemic has done some important service by actually pointing out how much the lack of redundancy in the Canadian health system and our ability to be resilient in terms of keeping up things that are critically important, not just for the health system today, but for people who will need it in the future. So there have been some good reports that are quantifying and actually predicting what we might expect in the incidence of cancer in the future as a result of delayed screening, postponed surgery, that sort of thing. But I think more importantly, in Canada, it's also served to point out how dependent we actually are on hospitals to deliver care to our citizens. And that's a broader question. It's partly about the organization and delivery of care, but to Minister Fedeli's point, on innovation, it also has to do with the relative slowness that we are adopting new technology that enables us to stop doing things in the hospital that we can and should be doing in the community. And I'm thinking about everything here from aspects of mental health care through to primary care. supporting seniors to be able to live longer independently in the community. Technology, not gadgets, but technology and our ability to adopt it and to transform our health systems incrementally over time is absolutely key to being ready for those challenges. And if something like a pandemic can bring, all of that, not just to a stop, but actually set us back in time, it's a real lesson for all of us, I think, no matter where you live in the country.
Minister Horn, I promise we're going to get back to some of the questions you raised there, particularly on technology and its usage. But Louise Binder, I wanted to ask you from the patient point of view, what was the most critical healthcare gap that the pandemic revealed?
So I'd just like to start by thanking you for inviting me and to say that as far as we're concerned as cancer patients, we knew that our system was profoundly fragile before this pandemic. There was no news here for us. There were already delays in diagnostics, in screening, delays in surgeries for cancer patients, and certainly we were not getting access, and still are not, to really innovative medicines that were coming onto the market because we have some really outdated processes for making decisions about funding of these drugs. So all that happened for us, I guess, in the pandemic is that the things that we knew, we now know the public knows. It's not just the patients who are saying it. Now everybody is a patient in a sense. So that's really what I would say is that now everybody's eyes should be open, and it's now time for what your colleague that you interviewed recently said, and that's a revolution. And to me, a revolution is actually not going to be resiliency, because resiliency, it really just means that you can take a blow like a pandemic and you can return to where you were before. We don't want to return to where we were before. As far as we're concerned, a renovation of our healthcare system won't do. What we want is an entire breakdown and rebuild, and we would actually completely revolutionize the system so that we don't have silo budgeting of our health, so that we take into account the other ministries, social determinants of health. We're actually missing a whole number of people who could add way more than just your 8% to your GDP because we don't take into account social determinants of health in our health system. So there were sadly not as many surprises for us as you might think.
Angela Bobuti, we have seen COVID-19 vaccines formulated and approved in record times with, a novel approach with the mRNA vaccines. And I'm wondering if post-pandemic, you think your industry will be able to sustain this pace of innovation?
Thanks for the question, Jean. First of all, I'd like to thank you for inviting me to be part of this distinguished group of speakers. We view health resiliency as the biggest opportunity and the biggest challenge of our times. I think what the pandemic has shown is that industry can and will step up. We will step up to the plate when we're needed. We have been doing a lot of work and a lot of thinking into how to build greater resilience into the system, how to have a healthcare system that is supportive not only of industry and patients, but also of the broader objectives of the government and of society. So what we want to see happen are to transfer the learnings from the COVID pandemic to build greater resilience for the future. The learnings include leveraging data, building better interoperable health systems, expanding access to virtual care, moving away from a break and fix approach to one that is more predictive and preventative, and that enables early diagnostics, better access to treatments and adaptive technologies, and views health as not a cost to be contained, but as really a driver for that resilience and innovation.
Governor Dean, from your perspective as a physician and as an American, is the current healthcare system built to incentivize the kind of preventative care and innovation that the other panelists are talking about?
No. Let me just say this has been a terrific discussion, and it's a little bit like the parable, the Indian parable of the blind man and the elephant, or the blind men and the elephant, because we're really not talking about a single cohesive system. Our systems are more alike than most people think they are, but they're not 100% alike by any means. The fundamental problem in the United States, and to a lesser extent in Canada, which is, after all, a fee-for-service, is we only get paid when people get sick. So this is a sickness system we have, not a wellness system. And until we start rewarding practitioners, drug companies, hospitals for keeping people away from their institutions, then we are not going to succeed. The business about capacity during the pandemic is a particularly difficult issue, because if you're going to build redundancy into the systems, that's very, very expensive, and you rarely use the redundancy. So the question is, do we really want to build redundancy? Yes, we've been exposed. We've had a terrible time. I think all the things that the previous speakers have talked about in terms of inadequate care are true on both sides of the border, but that's very expensive. What I believe is, unless you get rid of fee-for-service medicine on both sides of the border, you are never going to have a system that incents primary care and taking care of people before they get sick. We do want drug companies with these extraordinary cures. We do want good surgeons and remarkable surgery. But what we really need to do is prevent people from ever needing those things. And that is not the case in our system. And it won't be. Now, there are downsides to the other system. The downsides are we can cheat by seeing as many people as we possibly can in the shortest time possible. In the other system, we'll be able to cheat by not giving adequate care and then keep pocketing the difference. People are always going to cheat in every system. I don't think there's even 100% of doctors are not honest, and I'm biased. But we need a fundamental restructuring of healthcare system so that the reward is keeping people away from us, not putting people into our clutches.
Fred Horn, I'd love to get your response to that. One, do you agree? And two, can it be done?
Well, I certainly agree with Governor Dean, and 35 years or so of health policy work in Canada. I mean, it's amazing how many things stay the same. In our case, about 83% of our physicians here in this province in Alberta are on fee-for-service. I expect it's similar across the country. So, a discussion about incentives, I think, is really important, not just for physicians, but in particular with physicians commanding, so many of the other resources in the healthcare system through ordering lab tests and making prescriptions to the direction they give to other providers. There's a huge ripple effect of that fee-for-service structure that really goes against the notion of it doesn't mean that people don't get quality care, but it doesn't reward, it doesn't provide incentives for looking after the patient from a quality perspective and from a holistic perspective. So, an example of how the governor's point plays out in Canada is the silo effect that patients often experience between primary care, which our physicians are, our private businesses, clinics or businesses, the divide between that and other points in the system, tertiary and quaternary care. So the impact for the average Canadian is quite often, having to tell their story more than once, large numbers of duplicate tests, medication conflicts, things that boil down to, a lack of coordination because that incentive wasn't there for the outcome as opposed to the output delivered by the healthcare system.
Minister Fedeli, I'd love to hear your perspective on the silos that were just mentioned. There are silos within the healthcare system, but we're talking here about trying to create some synergy between healthcare policy and economic policy. Is there a silo problem there? Is there enough dialogue going on there?
Well, I can tell you, Jean, I also chair cabinet. And so today we held almost our 200th cabinet meeting since COVID began. Yesterday we held our 102nd Treasury Board meeting. Now, some of those meetings are 7 or 8 hours long, and they involve all of Premier Ford's cabinet ministers. So if there was ever a disconnect before, it's been overcome by the sheer volume. We see each other more than every second day, from whether it's the Minister of Health, Minister of Long-Term Care, my Economic Development Ministry. We'll have our Minister of Mental Health and Addictions, Minister of Colleges and Universities. We all come together. So, this emergency has really brought us together in this far more open dialogue, and it has really given us an opportunity to be able to meld all of the decision makers. So when decisions of health were made independent in the past, there's now at times, obviously, an economic lens put on it. We're making decisions on lockdowns. We're making decisions about schools, whether they're open or closed. We also not only have the health lens on it, but now we've brought in an economic development lens. So I've really seen a difference. I've been in cabinet a while, long before the pandemic, so I saw both sides. So I would say it is remarkable coming together. I also today signed my 2000th document virtually. I'm not in the legislature. It is in Toronto, and I live in Northern Ontario. So we've really seen how important broadband is right across Ontario and across the country. So we've learned a tremendous amount about digitizing as well, including digitizing our health system.
If I could just follow up on that for just a moment. I'm wondering if the health sector and the economic sector are talking to each other about the decisions that relate to the here and now, like opening the schools, or whether you are working strategically looking forward, trying to cooperatively figure out what long-term investments should be made.
That's great, a great question, because we actually are doing both, and we're doing them simultaneously. So we made a very, very difficult decision just this week to close our schools because of our rising numbers here in the province of Ontario. Very serious decision, which has consequences where we need to enhance our childcare programs, because so many are going to be needing that extra service. So we are working really hand in hand, but we're also looking in the future. We had a major investment from Roche Pharmaceuticals in November of about $500 million. We just a week or so ago announced a $1 billion investment of Sanofi in a vaccine. It's not a COVID vaccine, it's the Fluzone, the flu vaccine. So that's a serious investment that our government decided to invest in as well. We invested in the company. They're also going to put $500 million in research and development. So we brought in the Ministry of Colleges and Universities on that. So we really are taking care of today, day by day, hour by hour, sadly, as the variants are really having an ill effect. But we have a big lens on tomorrow as well. I'll end by saying this morning, 25,000 more men and women woke up to go to a job in manufacturing today than did before COVID. So we're seeing growth in certain sectors here, especially in the health sector, Jean.
Governor Dean, a couple of the panelists here have called for a radical remake of the healthcare system. We've been trying to do that in the United States for a very long time. And I'm just wondering if you could give us a reality check on how difficult it is to reform major systems to, as the cliche goes, rebuilding the engines when the plane's flying, especially when you're dealing with people's rice bowls.
So I'll do that. I'm going to take the moderator's prerogative. Somebody just asked a great question, which is, how do you see Canadian and American expats, communities, and diaspora playing a role in this? One thing we should do is erase the border in terms of healthcare. If I couldn't move to Canada if I wanted to, and for the last 4 years, I thought I desperately wanted to until January of this year. But I couldn't get Medicare. My Medicare is no good over here. And Canadians, now you have to control costs. Otherwise, we'll run up the cost for the Canadians. We don't want to do that. So let me explain what, at least on the American side, I don't know exactly how this works on the Canadian side, but I think there's probably some similarity. 80% of all our hospitals are not for profit. 55% of all our spend is in hospitals. So that works out to a little more than 40% of all the spending in America is in not-for-profit hospitals. Not-for-profit hospitals are wonderful. They put the most prestigious people in every community on their boards, so people who can raise money, who are well respected, usually just by luck of the draw, both Republicans and Democrats. It's the best lobbying organization in the world, because who do you think I go to as a politician to get myself elected and raise money? The most influential, well-respected people who can raise money in each community. This is almost a fifth of our gross national product. So anybody who thinks they're going to change this with the most influential people because they're on the board, this was not some devious system. It just evolved like this. So, but the forces against this kind of change are, one, it's 1/5 of the largest economy in the world. And two, the people on the boards of the largest spenders in American healthcare are the most prestigious, well-respected people in the United States. That makes it incredibly difficult to change.
I want to work in another audience question about delivery of service here. This person points out that in Israel, HMOs are incentivized per patient, not per service. The patient is tracked through their life and served, among other aspects, preventatively by leveraging big data, AI and electronic records specifically. Most recently, they were able to offer access to Pfizer and demonstrate the efficacy of the mRNA vaccine based on huge integrated data for millions of patients. Jana, I'd love to hear your thoughts on the Israeli system and whether they have figured out how to do this right.
I must say, unfortunately, Jean, I can't answer that question. I'm not a healthcare expert. I'm an economist. So I think clearly just looking at it, observing on what they have done with the vaccination, the speed and the efficacy and the results on the outcomes of the spread of the pandemic, I have been impressed, as probably have many others, but I don't think I am the right person to answer that question, sorry.
Does anybody else want to take a stab at that one? Otherwise, I want to move on to technology here, which was mentioned by several of you in your opening. Louise, telehealth mentioned repeatedly, adopted much more widely during the pandemic. Does that need to play a greater role in the healthcare system going forward?
There's no question that what I would call virtual care, what you call telehealth, has been a great boon for many patients during the pandemic. I think what we need to remember is if we're really building against fragility and for resilience and for the long term, we must remember that we put that in place in a state of emergency, which of course we should have done. But what one does in a state of emergency then needs to be revisited for the longer term use. So I would say that we need to definitely analyze people's experience with virtual care during the pandemic, learn what worked for them, what didn't, what could have worked if it had been tweaked in some way, and what interfaces are absolutely just not appropriate for virtual care.
Is anybody doing those studies that you're aware of?
I'm about to, since you mentioned it.
Excellent.
Yes, yes. Some of the cancer organizations are doing a study to look, and we're going to be, I'm very proud to say that not only are we going to be looking at the general population, but we're also going to be doing a very robust analysis of our indigenous populations, because they are often in remote and rural areas and have quite a use for virtual care. And we are going to be making recommendations. The minister from Ontario may be receiving a copy, no doubt, and others, about how we can really maximize virtual care. And if I want to say something about the economy and virtual care, I would say this: if we can save money by using virtual care in the very best way and only using resources, those very precious resources where there needs to be face-to-face intervention, I think there will be a profound saving in the healthcare system without a profound loss of good health for Canadians.
Angela, let me ask you, if I might, about data, which also has been mentioned as a potential accelerator of better healthcare. Talk to us a little bit about that, and specifically how it might impact your piece of this pie, which is, drug development.
Yes, thanks, Jean. You read my mind. In fact, I wanted to make a point to that earlier comment. We need interoperable data systems. There's no doubt that our health data is badly managed, badly tracked. In order to implement value-based healthcare and to have a system where your earlier question around Israel, to have that type of system where we are actually tracking the development of patients as opposed to the numbers and the activities that are run through hospitals and through the healthcare system, we need to have better health networks, health data networks. And there are various efforts underway through the private sector. We have been working with the Canadian Personalized Health Information Innovation Network, CFIN, that has been pulling together a number of different partners to implement these types of systems. But of course, there are a lot of options and opportunities out there. And it's just another example where should government look to a partnership, a collaboration with industry, I think they would certainly benefit from some innovative ideas and innovative new processes.
Jana, I know data is something that you looked at in your study. Talk to us about it.
For us was that while we have some good data about therapeutic treatments, because those are required to get a new molecule approved, for example, we have much weaker data on what really helps people to stay healthy, what reduces risks of what. More than anything, how can we help people actually make the healthy choices? We know what the risk factors are, but we don't know how to help folks. And that's because we haven't really studied and tracked the changes. And I think having large amounts of populations and having data on their behaviors, having the capacity to actually experiment potentially with different approaches, we would build the data so that we actually could help people take care of themselves better. And I think that is the big opportunity, because of course, we all know that prevention is cheaper than cure, and that in the long run is going to pay quite significantly into the savings overall, both the economic as well as the personal benefits of the improved health.
Angela, one thing that was talked about in the McKinsey report, of course, is preventative care, which I presume requires longitudinal data. Is your industry, does it have the patience to gather that kind of data that's needed to prove the efficacy of treatments?
Yeah, in fact, we are doing that. We've run a study recently in the UK to show how the adoption of medicines in diabetes specifically have averted deaths, hospitalizations. I think the number is 17,000 hospital admissions were averted in the UK, 2,700 ICU admissions, and 400 hospital deaths. So we're doing that. We're tracking how actual preventative measures and increased access to health innovations can avert further more costly interventions. And what we would like to do is for the government to implement similar types of outcomes measures, either through patient-reported outcomes measures or through longer-term data gathering, so that they can incentivize outcomes over activity.
Fred Horn, do you have any other ideas on technologies that we've discovered or should be discovering in order to create a better healthcare system that will deliver these economic rewards we're talking about?
Yeah, well, to be honest with you, Jean, I mean, I'm not an expert on technologies. As a health minister, and I'm sure others here have been in the same position where you agree to a meeting and you're presented with sort of a newest and best gadget, for lack of a better term, but with no context about how that piece of technology would be integrated in the total care pathway for that patient to produce not necessarily a cheaper, but a better outcome than what is currently being received. So we, at least, from a Canadian point of view, we tend to talk about technology in an isolated way. If we're talking about seniors, for example, there's a whole plethora of remote monitoring technologies that are available that can potentially connect individual patients to home care teams. If we think about more recently, if we think about just the availability of data and people using Google and other big tech platforms to ask and answer questions that they have that they can't get answered or don't have access in the formal healthcare system. There's probably an endless choice. I think in addition to, kind of utilitarian types of technology, we also need to think about why we want the data and what we want the data to do. And so in that sense, things like predictive analytics and the ability to have enough data about the right people at the right time to position the health system to respond earlier to needs, whether we're talking about, someone with diabetes who is at risk of developing blindness or other complications, or cancer screenings, technologies that support screening and early identification, or mental health, or many other things. We're not doing that. So we talk about technology in terms of how to automate things that we currently do, instead of talking about how we use it to enable new models of care. And I think Governor Dean was getting at that point as well. So that might help us get a little closer, to the central question today around the relationship to the economy. But that would be my take on technology.